Astaria Africa. Astaria Africa is distributing alpha-2 EQ. So thank you for coming, and I'll hand over to you.
Thank you. Thank you. I'm Ken Allen from the States, and I'd like to thank both Astaria Africa, Carrie, and Bill Kramer, who is somewhere on the internet in the world, for letting me have this opportunity to talk with you all. I've had a fantastic time here in Africa, and had the opportunity to go to Cape Town and Franschhoek, and then did a week in Botswana with David Foote and Ride Botswana, which I highly recommend. It was an amazing experience for a Missouri farm boy now turned veterinarian in Virginia. So what we're going to talk a little bit about and is alpha-2 macroglobulin. And this is a set of slides that our practice put together. We were approached in 2018 to do part of the safety study as they were trying to determine if this was going to work in horses. And so we did that, proceeded to do that in 2019, and found that we were very impressed with how it worked in horses. And then this is the update from the original safety study on kind of a year's worth of work. And then we've got now another year's worth of use that is not on this particular data. And Dr. Cricket Rosillo in our practice, and former U.S. dressage team vet, is compiling more of that data, and we'll present it this year at AEP at the end of the year. So this is our midterm report on what we found with alpha-2 macroglobulin, and we've been able to utilize it a lot, but let's talk about where it came from. So it was approved as an FDA approved device since 2013, and a fellow by the name of Dr. Scudieri, who's a spinal surgeon in Florida in the US, started trying to look for, he had used PRP in the past, and as we've all used PRP, and PRP can be very effective. But the holy grail has always been, and people have been searching for it for years, well, what is the anti-inflammatory component of PRP? We all know the pro-inflammatory aspect of it. And that's the problem, of course, is PRP has both a pro and an anti-inflammatory component. And what Dr. Scudieri was looking to do was figure out, he was a back surgeon, and he wanted something that he could inject in and around disc and nerves, trying to calm them, that wasn't a corticosteroid. And so he had some time on his hands, and he found a very effective way to concentrate this A2M. And so then 2018, Dr. Stuart Schumacher went ahead and did some studies on it, and on how we concentrated in horses, what its effects are, how it worked, did some of the laboratory work. And then that went into the equine safety study in 2019. They did an official product launch in 2019. And then we have the molecule. So again, what we're trying to do here is to say, okay, we all know PRP works, but sometimes it's a little bit more inflammatory than what we like. And sometimes we don't get quite as good an anti-inflammatory effect as what we like. So how do we deal with that? And that's why it's important to understand this molecule, because it's a little unique. It's sensitized by your liver. and the horse's liver. There are other smaller amounts of it made within the joint, macrophages, but they're much smaller. So this is more concentrated in systemic blood and less concentrated in articular joints. So then it makes sense of what we're attempting to do. We're trying to go ahead and concentrate it from the bloodstream where it's in higher amounts, and then stick it back into affected joints where it's in lower amounts. And that will give us the anti-inflammatory effect we're looking for. So it's a really large molecule, as you can see here on the slide. And that's why, of course, it's called a macroglobulin. And so it's 720 kilodaltons. So again, by the size of most molecules, that's big. And you can see it, and you'll see a graphic of it here in a minute, but you can see it grabbing these proteases. And we'll talk about the ones it works on, but it's unique in that a lot of other products will only work on certain protease classes. And proteases, of course, are the bad things that happen in our joints. When your joint gets inflamed, you've got a lot of protease inflammatory components sitting in that joint. And that's one of the things that I've learned from the human guys, because I've had my right knee, my left knee, if I need to lubricate it now, I just use WD-40. But my right knee, which is still biological, I use A2M. And I've injected that, and it's kept my right knee going for me for several years. Eventually, I'll have to have a total knee replacement on it, but it's kept it going for the last 4 years. And it's doing it. When Dr. Scudieri was injecting my joint the first time, what he was doing is actually trying to get all that fluid out, because all that fluid has floating inflammatory components and proteases in it. And so the more of that you can get out of the joint, the better. That's great. So, okay, we don't worry about that when we're doing cortisone shots. Oftentimes we just go, we're in the joint, let's inject it. But with this, if we can get more of the proteases out, the junk fluid that's inflamed, then this molecule has less to do. Okay, it's still going to go do its job, but it has less to do. Okay, so it's got a unique mechanism. So it's non-specific in its protease inhibition, which is, again, not many molecules get to say that. It's working on all 4 classes of the classic proteases, the MMP and the metalloproteinase, and the motif one I can still barely say, so I don't try anymore. But all of the classes of the protease, it's very effective on. And most of the other molecules that are trying to do this can't say that. It also then is modulating our interleukin-1 tumor necrosis factor. And this last point is really important, and there is some more research going on with this, is that it's upregulating some of the genes that has to do with your cartilage. Okay, and so that's important. So it's going to upregulate the anabolic portion and downregulate the catabolic. And that's what we want to see from a product we're putting in a joint, is making that cartilage healthier. So, and in this case, Y alpha 2EQ, and they have a very effective, and again, the guy who came up with this methodology is the one who figured it all out. And so it's his mechanism, and his mechanism turns out that it's much more effective than any other. There are a couple other groups in play that say they can do this with A2M, but this is by far the most effective. So it's going to help you with chondroprotection, protease inhibition. We were just talking about cytokine modulation. It's going to help gene regulation, which is very important. It's going to help us there. You can do it in a stall side approach. It takes top 60 minutes to do. And then it, unlike PRP and the PRP-like products, are going to give you probably more than you need. We regularly can produce 32 cc's of the A2EQ, and then we will utilize what we need, and then we will store the rest of it, freeze it for later use. And we have had great luck with the frozen product as well as the fresh. Now, in human medicine, they've never gone ahead and done the proofs that they needed to do to say you could keep it frozen. So they use it all that day. They don't use any frozen. They're just scared to do it that way, and there's never been a proof involved in it. But in horses, there has been work done at Boise State that shows that you can use the frozen product. Since they switched the methodology, right now they're only saying 6 months, but I'm quite comfortable that they will be able to say by the end of the year that you can freeze that for a year without a problem. And we've been utilizing it that way at our practice. So here's a graphic just showing exactly what this giant macroprotein is doing. And you can see that it's got this quad arms, and it's stuck together. It's this dimer. And then what happens is when they encounter the protease, then that goes ahead and grasp it. And that's an irreversible binding. It will not let it go. There's no competition for that binding site. They just grab the protease, they've got it. And then at that point, they're going to be excreted out. So it's a very effective molecule, and it is unique in that it kind of has two ends to it, so it can get twice as many of the proteases. Now, there's some important things that we've learned, and I will tell you that it's interesting. I've been attending and speaking at a variety of both human and veterinary talks over the years about PRP. And when we were doing the research on this, there became this question about, okay, well, what should we stay away from? And that question rarely gets asked, interestingly enough, with PRP. They do talk to you about, okay, you need to stay away from the non-steroidals in PRP. We all know that. Now, but is it just the COX-1 inhibitors, the more standard butanamine, or does that also apply to the COX-2 inhibitors? There have been some recent papers saying that the COX-2 inhibitors don't cause that much of a problem in affecting PRP. So now in this regard, we're utilizing just the PRP recommendation, which is at least a 5-day washout. I usually try to get clients to do a week of being off of non-steroidals, okay? But I suspect as we learn a bit more about this, we'll be able to figure out that the COX-2 inhibitors may not be much of a problem in that regard. Okay, I'm going to come back to this one last. No known interactions with bisphosphonate, shockwave, or laser therapy. We utilize all that concurrently. This was the surprise, was that alpha-2 agonists affect the circulating alpha macroglobulin in your body. And so that was a surprise. Dr. Shoemaker was the one who figured that out. in that he was looking at it post-anesthetic one time. And then he came back and did some more work on it. And there's a paper that he finally found on it as well. And so that means your democidine, your romifidine, your xylazine, those you want to stay away from during the collection portion, okay? Because they will affect the amount you have in your syringe as you're doing the collection portion. So it, you know, initially we thought that was a huge stumbling block. What we learned is it's a management technique. If we suspect we're going to be doing it on this horse, then we're just not sedating that horse until we do the draw. And then we do the draw. And then right after that, let's say we want to go do neck x-rays or something on it. And we are pretty positive we're going to want to use alpha-2 macroglobulin. We're just simply going to go ahead and do what we need to do, except for where we need to sedate the horse. Then before that, then we'll draw the blood. I'm going to walk you through that process. And then we will go ahead, sedate the horse, take the neck x-rays. So in doing the injection, again, alpha-2 agonists don't matter. None of that's a problem. Non-steroidals really don't matter. And that's not true of PRP. PRP, we usually recommend not using them in 5 days. Again, Dr. Shoemaker's got some data that shows that, you know, you can give a shot of Banamine with this if you want to. I don't personally, but some of my other veterinarians in our group do. They want to do that. I don't find a particular need for it. But if it makes you feel better, you can do it with alpha-2 macroglobulin, where you probably shouldn't do that with PRP injections, okay, based on the current research, particularly from the human. But this is the important one in that, and I've done it before where, you know, I just sent the horse in and I said, oh, I radiograph it. And they said, can we sedate it? And I go, oh, yeah, sure. And then later on, I'm reading the x-rays and I go to the client, oh, you know, and we can use alpha-2 macroglobulin on this. And that's about the time my intern taps me on the shoulder and goes, hey, Dr. Allen, we sedated that horse. And I go, or we could come up with some other things we could use today, or we could have you come back in 3 days. And 3 days is the washout. You know, if you can just postpone it, then you come back in 3 days. And actually, after that, the levels are a little higher. There's a rebound effect that happens. And Dr. Shoemaker has documented that as well. Interestingly enough, now when I talked to Dr. Scudieri as he was injecting my knee, and I asked him, I said, well, what do you do to increase your amount of A2M? Because that would seem like a wise thing. And he said, well, in humans, we've done some work on that. And he said they weren't aware of this alpha-2 agonist, but then humans are rarely receiving those. But what he said was you can exercise, okay? If you exercise prior to the draw, or say the day before, you go out and run 5 kilometers, 10 kilometers, he said, you will have a higher level of circulating alpha-2 macroglobulin in your bloodstream. And he said the other way to do it is that's challenging your body. The other way to do it is challenge your liver. And he said, if you go on a big drinking binge, and he said, you know, that would also increase the amount of alpha-2 macroglobulin, interestingly enough. So you have to run and then drink. That's the way to increase alpha-2 macroglobulin. I don't know how well our horses are going to do on that. They can do the running part anyway. Okay. So let's talk about how we do this, because this is what everybody wants to know, how difficult is this going to be for their practice, and, you know, can you make it happen? And so you need a portable centrifuge. You'd like to set this up in a tack room, you know, take the centrifuge out of your truck, set it down. Some people leave it in their truck. And that's the way they've been processing either PRP or, you know, Alpha-2 EQ over the years. So you can do it a variety of different ways, but it's best if you can try to keep it in a clean area. It's got provided sterile drapes you're going to set out so you can organize and set your stuff out. And then everything is in the kit except for the ACD. And so you need, and we have these small bottles of ACD that we keep just for this. And I'll walk you through how we do that. So you're going to go ahead and just prep. We don't clip at all. We just prep it with betadine. And then we're going to drop 6 mLs of ACDA into the 2 60 ml syringes. And then with the provided 19 gauge, you don't have to use their butterfly. You can use a 19 gauge or bigger. And then you're going to draw up 34 mLs of blood into there. So you've got a total in that 60 cc syringe of 40 cc's. And you're going to just disconnect it, mix the product a little bit, and then recap it and set aside on your sterile. You're going to do the same thing for the second 60 ml syringe. And then after it's, you know, after that's been collected, you can sedate the horse if you needed to, like I was telling you. And then you shouldn't let that blood just sit there. You need to move right along within the processing. That's your biggest clock running. You need to do it within 30 minutes, but that's easily done. So now what you're going to do is take that 60 ml syringe, which has 40 mLs of ACD anticoagulated blood, and you've got 8 vacutainers that are these kind of large vacutainers that you can see here and here. And you're going to go ahead and let the vacuum do the work. Okay, you're just going to take this blunt needle, which will punch right through there into the vacutainers and let it suck out the appropriate amount. You don't have to worry about it. You don't force it, you don't push it, you just let the vacuum do the work. And then you're going to take those 8 vacutainers and you're going to put them in the centrifuge. You're going to spin them about 3,400. And then the brake and these particular centrifuges that we're using, I thought I had a picture of it. There it is. Are ones that you can either engage or disengage the brake. You can use it both ways, which has some advantages because there might be some other things you want to do where you want to engage the brake. But here you're going to use it disengage. So it takes a little longer for it to spin down, but this is important for the process. Once you're done, then you're going to pull them out, just wipe the top with alcohol, and then there's a very clever little access device right here. And you can see what you're doing is you're putting the vacutainer in one end, that has a needle going up in there, and then there's this connecting, and your syringe down here is then drawing that plasma out, okay? And you're gonna connect each vacutainer and aspirate the plasma. And again, not very hard to do, quite easy. Okay, so then what you're going to do is take these conicals out, and they've got these little stabilization things. You're going to set them down there, and then you're going to put the aspiration needle, it's about a 4-inch needle, to this 50 ml syringe you have with the plasma, and you're going to put 19 cc's into each of these conicals. Okay, you're going to discard the rest of the plasma. Okay, then you're going to put the conicals, you just take out the little vacutainer. I forget what you call those little Well, you put the next little thing that will not hold the vacutainer, but holds the conicals. And probably at 2 o'clock tonight, I will think of the proper name for that. But so you're going to do that, and you've got 19 cc's in each of these. Okay. Then you're going to spin again, 3,400 with the brake disengaged for 10 minutes. So those are your 2 10-minute spins. Takes about 5 minutes to do those steps in between. Okay. And then now what you're doing is you're going to go ahead and take the conicals, okay, put them back in the stabilization. And then this is the only part you really have to pay some attention to, and that you're going to aspirate. You got a new 50 ml syringe, another 4-inch aspiration needle, and you're aspirating out here, okay? And you're trying to get all of the concentrated plasma you can get there without getting down into this little buffy coat. Okay, you don't want to get into that last ml. That last ml has white cells, eosinophils, some things you don't want necessarily. And we have had it before where we had a technician and she got a little greedy and she didn't bother to tell me she had done it. And she aspirated a bit. I didn't catch it. The fresh injection went fine. The frozen injection, we got a flare. And we were confused because we've done hundreds and hundreds and hundreds of these injections. Never had a flare. So we took the remaining frozen product, sent it off to Dr. Shoemaker, and he analyzed it and told us that was exactly what had happened. Is it was human error, and she had aspirated. It was loaded with eosinophils, which really weren't a problem in the fresh product, but in the frozen product, they had burst. And so the eosinophil products were in there and they caused the inflammatory process. So again, as long as you're just using reasonable care, like I say, we have now done thousands of these injections and hundreds of this processing. And that was the one time we had a problem. So if you just take care not to aspirate that last ml above the filter, and then what you do is then you go ahead and put the sterile female adapter to transfer into these smaller syringes. And the way that we do that is we tend to do them in 4 ml aliquots because that's a pretty handy, and I'm going to go through the amount we use to inject them. But we'll do that, and then we'll go ahead and draw back to 5 ml to give us a little bit of leeway there as we're freezing them. And so just so it's not pushing the stopper. And then we drop them in a sterile sleeve, and we go ahead and we've all handled that sterilely or cleanly. You know, you can use exam gloves with alcohol, or my staff is in love with sterile gloves, so they all use sterile gloves to do it, as I'm sitting there looking at the cost of sterile gloves versus exam gloves with alcohol. But they're happy to do it that way, and it works fine. You can do it either way. And so, like I say, you're going to drop them in there, and then you're going to use whatever you're going to use fresh, and then you're going to freeze whatever you're going to freeze. If you don't get it to the freezer immediately, it's no big deal. We try to refrigerate it. Let's say I wasn't ready to do my injection yet. It had to sit for a little bit, for an hour or so. We just go put it in a refrigerator. Okay. The frozen part, once you freeze it, it needs to stay frozen. Okay. So sometimes if we're doing this out clinic, we just ask the client, do they want to keep the frozen in their freezer? Can they do that? And then we'll just let them keep it, because we know we're going to be back out to their place utilizing it. But we make sure we write the horse on it, make sure we write the date on it, so we know how long it's been sitting in that freezer when we come back. So The injection technique is like every other injection technique. You know, you're going to do a thorough clinical examination, and you want to, of course, like everything else, you want to know what you're treating. So make sure you know that you've blocked the horse, you've worked it up, you've done all that basic stuff, and you're going to go ahead and inject it. And I try to note the amount of joint effusion, the lameness, and then what the diagnosis is. And then we'll talk about the volumes, but they're pretty standard volumes. And then we just inject it into the joint. So again, no secrets here. This is a pretty standard volume for what we do, whether we're using corticosteroids or whether we're using PRP or A2EQ. We're going to go ahead and put, you know, the cervical facets can't take large volume. So they're the 2 to 4 cc's. Bursas are the same way. Bursas now, you know, I used to kind of rush because it's always awkward doing a navicular bursa, however you're doing it, ultrasound guided or X-ray guided. And, you know, now I take a little bit more time and try to let more of that stuff drip out. Every once in a while, I even pop a syringe on it and try to aspirate a little out, trying to get more of that protease-laden fluid out of there so I leave less work for the A2EQ to do. Digital sheath, easily take larger volumes, 4 to 8 cc's. Tibia tarsal, you know, plenty of space there. Again, this is the joint that throughout my career has always been my boogeyman. If I'm going to get a flare in something, it always seems to be the tibiotarsal, and it doesn't matter what you use. I'm convinced I could probably put saline in there and get a flare with a tibiotarsal. A2M has actually done fantastic on it, but it's a joint that makes me nervous. When we're doing the DIP joint, our standard volume is 3 to 5 cc's. Sacroiliac, a little larger volume there, about 5 cc's. Fetlock, 4 to 5. The small tarsal joints, we tend to put about 1.5 to 2 cc's in each of the either the tarsal metatarsal or the distal intertarsal joint. And then we'll talk a bit more about intralesional and perilesional, and then of course stifle, medial femoral tibial, about 8 cc's. So this was a summary of 180 horses, about almost 900 injections. Again, we have that one flare that we talked about, and that particular one was different than the other one I was talking about, and this was with a fresh injection. And we never did determine what that was, but that was a tibiotarsal joint. So it always made me suspicious about just the tibiotarsal joint. And again, we did these from January 2020 when we weren't doing near as many, all the way through September 2021, and now we've got almost another year's worth of data now that's not in this chart. So you can see there's a bunch of bursas, coffins, pasterns, fetlocks, carpus, some elbows, shoulders, a lot of hock, 221 hocks, 52 stifles, 106 backs. We're talking the individual injection sites here. Neck, 173, 44 sacroiliac. Tendon sheaths 11, and well, tendon sheaths can flare. They don't do it at the rate that tibiotarsal does, but this works really well with tendon sheaths, and I like it a lot with that. And then we're going to talk more about the soft tissue. You know, we just tried to break these cases down. We didn't want to use a case that we were shock waving the same joint. With alpha-2 macroglobulin, again, we do the shockwave before and then do the injection. PRP, we do it exactly the reverse. We do the PRP first, and then Katie Seabaugh published a really nice paper a few years ago out of Georgia, where she showed some increase in the activation of the PRP alpha granules with shockwave. No evidence that that helps you with A2EQ. So we do the shockwave before and then do the A2EQ injection. So we made sure that we were not doing adjunct treatments on these joints, and then no additional injection therapies were performed in the same limb. And then we did a recheck performed within 8 weeks, which was quite different than our original. And I tend to re-see my cases at about 4 weeks, but some of the other practitioners in the process may go as long as 8 weeks for their rechecking. But we're all rechecking them. And what I was impressed with in the safety study is that we were checking those at a week, and I would see coffin joints that would have significant effusion as I'm palpating them. And a week later, those things were flat. And I was very impressed at that because I can barely get that effect with corticosteroids, usually not that good. But it works very quickly in those soft tissues. So just run through, we're going to run through these various coffins, hocks, neck parameters. And then here's how we scored: mild, moderate, moderate, severe, and then the numerical findings that go along with it. Sound is 0, 5 is severe. And then we looked every time at joint effusion, lameness grade, flexion response, and pain on palpation. So the coffins, again, 19 horses, 38 injections, that same criteria. We got almost 80% of 19 cases had improvement. The initial effusion score was 2.3, post-injection was 1.3. So that's a significant drop. Initial lameness grades 1.4, so you can see these horses weren't all that lame. A bunch of these were dressage horses. And so you're looking at much more subtle lamenesses there. But you can see you get them down to a half grade. At a half grade, you know, I quit measuring at about a half grade because I can't see anything. So it improved the horses significantly. Hocks, 14 horses, 28 sets of hocks, hock joints. And then these were all, again, sport horses. 85% had improved flexion responses. Easiest way to evaluate it, all these horses were more sound. And so, you know, 57% had 1 grade of improvement to flexion, 10% had 2 grades of improvement to flexion. So if you can get that out of the hocks, that's usually pretty good. Necks, again, it works really well here on necks. Now, I have to admit, I've had good outcome with PRP over the years on this. Corticosteroid also works well. It just doesn't last very long. But necks seem to be a really good spot for this. And so, you know, we're evaluating those from both what the clients are telling us doing lateral neck flexions on the horse and trying to pull it into a posture, and 71% of the cases look significantly improved. And you can see that 43% improved 2 grades, 17% 1 grade, and then 10% improved 3 grades. So again, you can expect some significant improvement with this. Soft tissue is interesting. Like I say, tendon sheaths tended to be the deep digital flexor sheath most commonly one injected. The periligamentous that we did, the way we did this is and Dr. Rosillo gets credit for figuring out on doing branches. And branches, of course, lower suspensory branches tend to be the bane of the dressage horse, but they're also common in eventers. So we see a fair amount of them, and they tend to be a more acute injury in the eventers, and they tend to be a more chronic injury in the dressage horse. And what she came up with was a method of using the mesotherapy injectors. And I take, you guys are familiar with the mesotherapy injectors, a little mini injector unit where they have 5 little ports coming up. You put the little 27 gauge needles, you know, they're only a ½ inch long on them. And then you attach that to your syringe and a tube, make it flexible and easy to use. And then you're going to go down there on that branch and inject. And so what she found is it was quite easy to go ahead and inject right along the sides and the front of that branch. And it's pretty awkward to do that with a regular needle. This makes it a lot easier. And she found, like what we did as well on all the periligamentous injections, is that alpha-2 macroglobulin has a profound effect on soft tissue injuries, which was not my initial thought. I guess if I'd understood what it was developed for at the beginning, you know, to go around disc, it should have made more sense to me, but I kept having in my mind joints. It's there for the joints because it does all these magic things with the joints, but it also does some really magic things with soft tissue. And so what we've learned since then, we've done a lot more of these on the proximal suspensory ligaments, because a lot of them that we diagnose in the hind limb in particular tend to be swollen. And so the horse is lame, painful on flexion, you've blocked it, ultrasounded it, you've diagnosed hind limb proximal suspensory, and there's usually no big core you're injecting something into. But the characteristic, and a lot of papers have been out there, and they've had mixed results on putting PRP kind of indiscriminately all over that origin area. And some of the papers describe it as periligament, some are intraligament. And so it's an interesting thing that what we found is that what you can do is just take the alpha-2 macroglobulin, slide your needle in there. If you do this with a tibial block, it's a lot easier. I can tell you, otherwise they don't appreciate it so much. Slide your needle in there right at the origin, and there's a small space even when they're swollen. And you can find the space by just backing the needle out with pressure on it, and then you'll find that space, and all of a sudden the needle will go easy. And what you're doing is just flooding A2EQ all around that swollen proximal suspensory, and that has turned out to be a game changer for us. We've really had some great success. I've quit using PRP in that area, and I've gone strictly now to using A2EQ in that area on those swollen. And we tend to see a lot of them because we see so many eventers, jumpers, dressage horses. Now, intralesional, you know, we have fairly small numbers here. We've done a lot more since then because, like I say, the reason these numbers were so small is because we had not yet kind of clicked to, oh, wow, this is going to be really impressive on soft tissues. And since then, we figured it out. And so I had a really badly torn suspensory mid-body. And this thing was huge and I had holes everywhere. And so I just, you know, the client wanted me to use Alpha 2 EQ. I wasn't sure how it was going to do. I started just infiltrating all around in the lesion, periligamentous. I put probably 20, 25 cc's up and down that lesion. It was truly impressive. I went out and rechecked. I wanted to see it early. The swelling had reduced significantly on that. And I went out to see it at a month. I mean, the horse is not sound. Don't let me kid you, because I mean, this was a horrible injury, but it looked a lot better than I thought it was going to. And while I could still get pain, it wasn't the crippling pain it had had before. I had another case where I did it was a fasciitis. And the fasciitis tends to be this, this mid-cannon, usually front end lesion. And it's that fascia that is right in between the deep digital flexor and the inferior check. And that fascia, which is paper thin normally, and it will become very thickened in that area and fill that space. These horses are very painful, usually quite lame. It's a relatively rare lesion. All these others I'm talking to you about are pretty common. But I was impressed at that because I had used corticosteroids over the years. I've used PRP. I've tried just rubbing it with Surpass. I've tried a variety of things. Nothing really worked very well. I had one horse that I was trying to get ready for the 2010 WEG, and I never could get that horse right in time for it. So what I did with this horse is I said, well, we're going to try the Surpass, and it came back in 2 weeks and it looked no better. So what I said is, okay, we're going to try this A2EQ product. And I said, my associates just come back, Dr. Rosillo, from using it in Florida and telling me how well it's working on soft tissues. And I'm going to try that. So I went and infiltrated this all along that area, and right on top of that fasciitis. And then I had the horse come back in a month. And when that horse came back in a month, A, sound, B, except for the clip job, I couldn't tell which leg it was. And I go and palpate it and I get no response. And I'd never had a response like that in that particular fasciitis before. So I was pretty impressed with that because, you know, when you get as old as I am and you've seen something you've never seen before, you get excited. So we've done a intralesional since then. You know, we'll do it intralesional. It works well. I don't know that it's dramatically superior to PRP or stem cells, but it's probably the equal of them. And so these just a list of the things that we put it in intralesional. I have to admit, I've used it intralesional. I've used it periligamentous. Periligamentously, I can get it to do things I can't do any other way. Intralesional, it's good, but we've also got other things that we can have an effect with that as well. So, you know, this is just a summary of what we've been using. I haven't gone through everything. We've used it on navicular bursas, used on sacroiliacs. We've used it on articular facets in the neck and the back. And like I was telling some of the practitioners earlier, I've got a paper that we're trying to get into pre-publication that is describing its use in backs. And there we used both either alpha-2 macroglobulin or we were using PRP, and we were using cortisone and all three of them worked. It's just that if you look at it statistically, they all three worked, but the alpha-2 macroglobulin and the PRP both lasted significantly longer than the cortisone. The cortisone, the pain response on it dropped fairly quickly in just a matter of a few months, and those horses became painful again. And so where the other products did not, they did quite well. We've been impressed at all these structures that we've used it on. And I'm going to show you a few slides on new applications. Now, some of this I have not done, but I'm kind of interested in it. Laminitis is one, and then what the inclusion criteria is to treat it with A2EQ with regional limb perfusion, and they're using 10 mLs of it, and then diluting it with 10 mLs of sterile saline and doing a regional limb perfusion. Now, I haven't done a ton of this, and I can show you. I would think it's like every other laminitis case in the world. You're going to do a lot better if you treat it early than you are if you treat it late. These were the outcomes. Again, I don't think any of these are our cases, but these are from various practitioners that Astaria had organized. And you can see, you know, there's an acute, very bad founder, and that's the one no one wants in a treatment group because they're not going to do very well. A chronic one here, the second one, no improvement. A chronic one here that did improve. So, you know, again, and with laminitis, there's always the question whether you have inflammatory, you know, dermis, or do you have mechanical rotation already? And so the mechanical things like this first one, you know, you're not going to do much about. Doesn't really matter what you use. But some of these others, you know, that did improve, I was impressed at that. And then there's an acute one they got and did just one treatment and the horse riding again. So this may well have some application, but it's early days on this, and we're just starting to do these cases. This, I think, is pretty interesting. It is actually a case out of our practice, one of our technicians. You know, about, we were trying to say, could it, since we know it has effect on soft tissues, could it have an effect that will help with wound healing? And so here you can see a case that's pretty ugly over on that slide on the left, and, you know, swollen and cleaned up, a little bit better now. The edges are starting to get better. This one, sorry, you can see the one on the far left, the picture was taken from further away and now it's taken closer up. The middle one actually looks better. It's just hard to tell because of the perspective, but you can really see it here now on this last one, how quickly, and this is just a matter of a couple of weeks that it has started doing this. And then here's another wound. This is Dr. Reiner's down in Southern Virginia. And he had a pretty ugly case. The wound had dehisced, was looking pretty ugly. And then this last one is 2.5 weeks after a single injection. So again, some fairly impressive effects with it on soft tissue. And then other one, looking at bleeders and asthma, and the way this is being done, and this is pretty interesting to me. And we're trying to do a lot more of this. And we've got a project going on in our practice. And what we're doing is we're drawing the A2EQ And we're going ahead, and then you're taking a flexi-neb, and then you're using 3 mLs of it, and you're walking the horse. So it's inhaling that as you're going. And I initially didn't quite get that this was going to be an important use for it. But I had a hunt horse, and he has chronic asthma and has for years, and he'll bleed on a regular basis if you don't watch it. We've treated it with corticosteroids, inhaled, done a lot of stuff. He's been a difficult horse to manage. And I heard about this, and I said, well, let's do this. And we have a medicine practitioner in our group, internal medicine, and she said, well, you remember on the BAL results on that case is that that horse has a lot of eosinophils in its BAL lavage. And she says, those are really hard to get, Kent. I don't know this is going to be a good case to do it on. So we did it, and just did that, redid the BAL lavage, and no eosinophils. The horse is looking fantastic. And that horse went back to hunting, and then we kept him active during the summer after the hunting ended, and was fantastic. And he did fantastic for 6 months. I'm not saying they're all going to do that good for that long, but it was really impressive to me how that worked. And I wasn't really expecting much. And that worked at least as well, or in his case, better than an inhaled corticosteroid. So there's a lot of potential. This is a really interesting molecule that I think can do a lot of things. It's easily the equal, and in some cases, very superior to corticosteroids. And again, it has only the anti-inflammatory effect. It doesn't have the pro-inflammatory effect that you're going to get with PRP. So that's what makes it unique and sets it apart. So that is my talk. I'm happy to answer any questions. Why don't you go ahead and get the microphone?
Have you had any use in infected joints?
I haven't personally, knock on some wood here somewhere, but it should do quite well. Again, people have used PRP in infected joints, and I would expect the way, if I had one, the way I would try to do it would be to lavage it out, using whatever method you can use, and then follow it back in and leave the alpha-2 EQ in it, because then I flushed the junk out that I could get. And then I always worried, we always put antibiotics and such in there. I think this is going to be, it doesn't care where these proteases came from, whether it's an infection or it's concussion. It's just going to go after them. And then if I saw that that was helping me, then I'd take some of my frozen and I'd hit it at, every other day or whatever it took. I have no doubt it would be pretty impressive. Whether it's going to be enough depends, of course, upon the joint and the difficulty you're having with that joint. Oh, good question. Any other questions? Yep.
The freezing aspect, are there any temperature issues in terms of the freezer fluctuating?
Well, that's a great question. And when Dr. Shoemaker was doing that original work on it, that was a concern. Do you need that really super cold freeze, or will regular freezers? And regular freezers go through a bit of a warm and cool cycle. They're not quite as solid as we'd like to think they are. But it didn't seem to matter. He analyzed both deep frozen and normal commercial freezers, which have that little bit of a cycle to them. And it didn't seem to matter as long as they don't visibly come unfrozen. And that would be, of course, the nightmare. And we store these for a lot of our clients are stored in our freezer, in a special freezer. Now, learning what I learned after IRAP years ago, back when I used IRAP, is we had the perfect storm. The power went out, the generator that was supposed to kick in didn't kick in, the alarm system, which was on the generator, didn't go off because the power wasn't on. And so we lost a whole client's freezer's worth of IRAP. And, you know, that was enough for me. And I went away from freezing products until A2EQ showed back up. And then now what we do is we now have better freezer, better alarm system, better generator, but we're still doing that. And so when we're saying they want to store it, we offer them the option. Do you want us to refrigerate it? You can take it home, put it in your freezer, or do you want us to do it? If so, we're asking you to sign a disclaimer telling you we're doing all these things, but you know, we can't control nature. And if they all thaw out, we're not liable. So it's a hold harmless agreement. But, you know, as long, and I think the more complicating ones is, say, the client is going to go to Florida and they want to take their A2EQ with them, or they want us to mail it down to them. And I said, that's really difficult, guys, because that's now dry ice. You've got to have dry ice. No amount of other will work. And so, you know, there are a lot of shipping companies that won't ship dry ice anymore as the coolant. And so I say, if you're going to travel down to Florida, you know, you can do it. You got to get a lot of dry ice. You got to peek in at her once in a while and make sure that dry ice isn't gone. And you've got to add more on the trip down if you need to. So yeah, you can do it. There's ways around it. It's awkward if it's an ambulatory client, you know, you're going to go and they're going to take care of that stuff and keep it in their freezer, have them do that. If it's at your practice and you're going to do it, well, then great. Do it that way. So you can do it either way, and a regular commercial freezer works just fine.
We have a question from one of the dialed in members. The question from Ingrid is, do you use an antibiotic interarticulately after injecting the product?
No. And I can answer that one. And there is a lot of work, you know, this came up about, 30 years ago of starting to use antibiotics. And, you know, I was saved from it because I went to AEP and I heard this. And back then, they hadn't even started recommending amikacin yet. They were starting to, you know, that all came out of Colorado. And they were using ginseng then. And so I promptly went home, told my associates and colleagues, I've learned a new trick, and this is the way you do it now. You put antibiotics in with the cortisone and HA. And I promptly flared both hock joints on this horse. And it calmed down and was okay eventually, but gave me heart failure for a short period of time. And I have never put an antibiotic in there. And this is now 20,000 joints later, because that was 30 years ago. And I just, don't believe in it. There's lots of science coming out now where they're very detrimental to some of the joint. And a lot of the lot of the products, stem cells in particular, very negative effects with antibiotics put in there. I have not seen the work done on that in human medicine because they would not allow it. That would be malpractice in human medicine. And so I just don't think there's a good rationale for it anymore. And there's multiple areas of data where they say it's bad to do. So how we know it's a negative effect on stem cells, we don't know what it's going to do with PRP or A2EQ, but I would strongly recommend against that. And I personally don't think it's needed. I think you do a good job scrub with chlorhexidine, and I don't think you need it.
We have another comment that has come through on the chat. The comment says, after using it as a mesotherapy therapy in backs, you mentioned it lasts longer than the cortisone, even if doses of cortisone are so low in mixture being used.
Yeah, I need to clarify that. I wasn't talking about using this as in mesotherapy on backs. What I was talking about is using a mesotherapy injector system to infiltrate it along suspensory branches. Okay, so I probably confused someone on that. Apologize for that. I can see no advantage on using A2EQ along backs in mesotherapy. I think you're much better off with the standard mesotherapy concoctions. Everyone has their own, it seems like nowadays. But the important thing is on a back, if I were using it, I would probably be using it either on articular process osteoarthritis in the caudal thoracolumbar area, or I would be using it in between kissing spine areas, which we do fairly commonly. And then, like I say, to further re-explain that, on the suspensory branches, so these would be chronic inflamed or acute inflamed suspensory branches that would be very responsive to flexion, responsive to palpation. They're big, they're thickened. You look at them with ultrasound, they have kind of this chronic hypoechoic change, blotchy look to them. They're thickened. And so what we're just talking about is using a mesotherapy injector device with the same sort of needles, so we can just right under the skin where the branch is sitting, we're just trying to periligamentously infuse along that area to try to bathe that A2EQ into and around that branch. If the lesion is on the back side of the branch too, which usually they're not, but if they are, then I'll take a little bit longer needle and go down and infuse that. And if I'm doing that, I'm usually doing it guided. Okay. And again, back, and I didn't explain that, but all these necks, we're talking about the back OA articular processes. Those are all guided techniques with ultrasound. And so here I get to say, and if you're not comfortable with that, you want to get more comfortable with that, you can go to ICELP. ICELP, hopefully most of you know what it is. International Society for Equine Locomotor Pathology, founded by Jean-Marie Denois, and other speakers now are speaking at it now. We have Kurt Selberg, Eric. Eric's going to kill me. Yeah, Eric is great at this. But we have numerous settings. So we take the horse and we break it down into 8 sections, and we go through the anatomy, the physiology, the treatments, the ultrasound lesions, the guidance, the non-ultrasound diagnostic. Eric Bergman is our vice president, and he will make me buy him a beer for this later. But it's an incredible, if you've not, have any of you taken some ISELP courses, or a few of you? They're now live streamed, so like everything else in the world. And so we do 4 in the US, we do, and there are 3-day modules. And online, when you do it, they're 17 hours, and they do run almost continuously, but it's all recorded for you. You have a code, you can go back and look at it as much as you like. So you don't have to watch them live. You don't have to do it in the middle of the night. You can watch them whenever you want to watch them, and you can ask real-time questions just like we're doing here. And you can get comments back. So if you haven't gotten into ISELP and learned, there are a lot of practitioners that it has changed their way of, and I'm one of them, changed their practice and their way of doing practice, and has been a huge boon to their clients, because now you are going to go look at things with an ultrasound with a confidence and a knowledge base that you never had before. So can't say enough about ISELP. Anything else?
If you're going to repeat using frozen LP2, when would you do that? Is that a routinely done thing, or would you do it only if you had an additional flare-up?
Well, great question. And it brings me back to say the difference, because a lot of people try to compare IRAP to this A2EQ. And they're different, a variety of different ways. IRAP, first generation, the original orthobiologic, okay? This is 4th generation, okay, orthobiologic. So we've learned a lot in the meantime. Back then, what they would say is, yeah, you got to do it weekly or every 2 weeks, or, to get that effect, because it wasn't all that effective at getting rid of those inflammatory mediators. Okay. So, and then there's a lot of other things now that again say, oh, well, yeah, we've got all these inflammatory mediators, but nothing is as powerful an anti-protease. I mean, it has other effects and it works other mediators like we talked about as well, but it is more powerful. It's the 4th generation, and it doesn't have the inflammatory byproducts. That's what separates it so much. So the answer to your question is, when I'm using it, let's say I've got a horse and it's got bad coffins and bad hocks, and I'm seeing that horse, and I used to see him on a regular basis, every 6 months or so. And I would re-inject him with cortisone. And, what we're all learning now, and there's good data on that in human medicine, and most human medicine now, you show back up and, you're injecting your knees multiple times. And after a while, they're going to go, after about the 3rd time, they're going to go, nah, we're not going to do that anymore. We know that's thinning your cartilage. We're making the problem worse, not better. So with the orthobiologics, that horse that I'm doing their coffins and their hocks on every 6 months, I just switch it over to A2EQ, and I'm doing it. I know now I'm not thinning. It works every bit as well. I'm not doing it in shorter intervals than I was before. It's about the same intervals, and it's working quite well. And so, it's just, you have to you know, talk to your clients and convince them why you're doing this, and you're doing this for the long-term health of their horse. And you know that, and there are some that's they get it instantly, and there are others that go, yeah, but it costs a bunch more, and we're going to do cortisone. And what I say to them is, great, we'll do cortisone, not a problem. Just remember, if this works, we're ultimately shortening your athletic lifespan of your horse. We're thinning the cartilage more and more. If it's just the first time you did it, probably doesn't matter. If it's the 5th time you did it, it's probably going to start to matter here in a bit. And so you want to see this horse more down the road. Hey, maybe it's cheaper to put a little bit more in it now and not have to go buy the new horse. And that's my rationale to them. So.
I've got 3 questions. Where exactly are you on the research in small animals? My second question is for humans, would it be the same spinning process? The same, I mean, clearly you're going to get a different amount of alpha-2M out per human, but would it be the same alpha-2M essentially? Is it the same process?
It is the same process. And when I went down and had my knee injected, you know, it was exactly the same process. And at that time we were using the same machines. Now there was one more filter machine in the original kit. And I don't know which one you're using. Are you using 2 machines or just the one centrifuge? Single, yeah. And then it switched about a year or so ago to this to make it easier for practitioners. So they only had to have one centrifuge to carry in their truck. And so that has made it simpler for them. And so that's probably the one that's different now. They haven't approved that device in human medicine. The original device was the original one used in human medicine. Now we're using one, and I will tell you the advantage of that one, that single centrifuge methodology that we're using now, is that you will get a very consistent, well-concentrated 32 cc's reliably, where the other system, which they'd use in human medicine, there were some days you got 40, and there were other days you got 20.
Is that due to the centrifuge or due to the amount of alpha-2M that you can get out of that individual?
I think it was actually the filtering process, which is the skip now that step is skipped, and now it's the second spin. And it seems to be more reliably concentrating. And again, there's some new work, and Dr. Shoemaker's been continuing to do work on this, even during COVID times when it was hard to get any work done. And, you know, determining that you were getting a pretty consistent dosage of the A2EQ molecule in each of that you're making now. So we've been very happy with this newer single centrifuge system. It's worked well. Your answer to your question on small animal is I don't know. You would think it would make some sense. They don't do a ton except in hips of interarticular and small animal, hip, shoulders, where we do a lot more. I would think the periligamentous and say intradiscal effects of it in small animal would be fairly profound. I would suspect you're going to have a little bit more trouble sometimes where it's pretty easy to get, you know, 60, 80 cc's of blood out of a horse, no problem. You know, some dogs, no problem. Cats, small dogs, more of a problem. So I don't know, and if Bill is on the line, maybe he can say something for us, but I don't know the answer to that.
Two more questions.
Sure.
Bad side effects. Can you talk for a moment about that? And then the other question is, Mike Ross was talking about the current centrifuge that you have, whether we could use that. Maybe you can discuss that with Kent. Let's discuss those at the moment. Then I have another topic I'd like to talk about, and that is, you mentioned the word concussion. Is there any work that is being done of alpha-2M in the brain?
Oh, and sorry, when I was talking concussion, I meant foot concussion on the foot. Excellent question on the brain, again, because, and you're going to have to ask somebody considerably smarter than me this question, but it has potent effects upon the brain. I had an ophthalmologist in our clinic the other day, and I was trying to talk to her. I said, this is the most profound anti-inflammatory effect I've ever seen. And, you know, we've all seen these eyes and how bad they hurt. And so I would be really curious as to how it would work, you know, how they'll use serum dribbled in via subpalpebral lavage systems. I would think alpha-2 macroglobulin will work superb on that, and maybe be enough of a effect to stop some of this. You know, you get this melting cornea that's very difficult to stop, and maybe A2EQ would have a significant effect upon that. On the centrifuges, the big deal is that you know, Horizon is the company that worldwide makes most of these centrifuges. They make them in every country in the world practically. And they make them with variable speed that you can run up and down the RPM, and they make them so you can engage or disengage the brakes, or some models they make where you can't disengage the brake. If you are using multiple modalities of orthobiologics, you're going to probably want a centrifuge that you can vary not only the RPM, but vary whether or not you can engage and disengage the brake. That's what you get when you're getting this, because you have to run it with the brake disengaged. But you can re-engage that brake and run probably other orthobiologics. I'm not an expert on that, but that's what you care about in a centrifuge. That's really all you care about. And then, like I say, most of them are made by Horizon around the world. What were your other questions about?
Any bad side effects?
Bad side effects. Yeah, all the dirty laundry was out here today. We've had the one flare, which we know is human error. We had the other one that was a tibiotarsal joint that was fresh, and that's it. And you saw the number of injections we've done. That's our flares. So I hate it. I was on a call with another orthobiologic that I was having a lot of problems with, and I was sitting there with a bunch of other people who are very knowledgeable and using this product, and I go, I'm having flares with this product, and they go, oh, no, none of us are. And I'm sitting there on that call and I'm going, somebody's lying, and it's not me. You know, we've got to be pretty honest about this stuff, because, you know, putting things in joints is a big deal. And I'm really big on, I don't usually like to be the first person to put things in joints that I don't know what's going to happen. And I will tell you, all of you that I'm talking to today, that we have had hardly any flares. And so in that regard, easily in my hands, the best orthobiologic I've ever used. the least flares, the least reaction of anything. And like I say, I am amazed on those, like the wounds I showed you. It has effects on soft tissue that I guarantee you we haven't figured out yet. And so it's got horizons yet to, and I hope somebody tries it on an eye someday. I'm going to try to talk that ophthalmologist near us to do it, because I'm convinced it will be significant. So that's what I have to tell you guys, unless we got something more. Okay. Just remember, I have to make my flight.
Okay. So the question is, I think you mentioned getting a paper ready for publication. Is there any published data in controlled studies with horses, e.g. with induced osteoarthritis, or comparative controlled studies with thank you, or PRP? Thank you.
Yeah.
From Patrick Page.
It's a good question. And, you know, I think I'll try to put it in perspective for you, is that when I went to the Orthobiologic Institute the first time, and I was listening to Arnie Kaplan, who's the god of the stem cell, and he's the guy who first kind of figured it out. And I got to meet him later, and he told me he really wanted to name it Kaplicites, which is his last name. And I told him I didn't think that was going to fly now. They're going to stay stem cells. But we talked about the number of papers that were available. So if you want to talk about PRP in human medicine, there's 10,000 papers, and they're varying quality. And then if you want to talk about PRP in equine medicine, there are 200 papers of varying quality. If you want to talk about alpha-2 macroglobulin, who's the new kid on the block, there would be less than half a dozen of varying quality. The paper we have been working on, and we presented it as a abstract, a poster, at North American Regenerative last fall. And that was comparing injecting the articular processes, or facets, whatever you want to call them. Professor Denois tells me I should call them processes, so that's what I call them. And injecting that in the back and comparing, we had PRP and alpha-2 EQ injected into that, and we were comparing those orthobiologics against corticosteroids. And the effect that we saw is we could not statistically discriminate between either of the orthobiologics and the cortisone as far as effect. Okay, so that's what you want when you're doing this. If you're going to say the gold standard is corticosteroids, you want to be statistically not different than them. And that's exactly what we found. Then what we looked at, we thought would be the next most important thing. And we, I wish I had found this human paper sooner, but we did not find it to the end of our process because it was a Chinese paper and my Mandarin is extraordinarily bad. So I had to get someone to translate it for me. And what they had done is they did a prospective study. We did a retrospective study, and they found exactly the same, no difference between, they did not have the luxury of alpha-2 macroglobulin in theirs. They just had PRP. They were comparing that against corticosteroids, and they were identical. Again, same as our paper. And then what they showed was, however, is that as the effect of the corticosteroid came up fairly quickly, but then started waning over a period of a month or two fairly quickly, the orthobiologic that they were using, PRP, kept going. And by the end of their study, which was 6 to 8 months, was still on an upward trajectory, okay, where the corticosteroid had already tanked and was done several months earlier. We found the exact same thing in our 2 orthobiologics that we were using, alpha-2 macroglobulin and PRP. And remember, this is a specific joint we were doing, the thoracolumbar articular process, OA. And we were injecting that into that, and we found the exact same thing. Corticosteroid waned fairly quickly, and then the orthobiologics continued on. What we need is more studies like that. What would be ideal would be to have comparisons and randomized trials. Now, it's almost impossible to get the funding to do randomized trials like that now and double blind. They just don't exist. Look how few papers you see with them nowadays. So the money just isn't there to do it. The good news is there are a lot of practitioners who are utilizing a variety of things. And if they can consistently put in their medical records what they're seeing and not seeing, is then you're going to have the opportunity, like we have, to go back retrospectively and mine your medical records and then publish a retrospective. The other thing I thought was pretty interesting as we went back and looked at that data was that the amount of time that, and one of the things we did, one was the length at which it lasted, which we don't really have endpoints on it now. But I can tell you I've kept track of the ones that we did twice with an orthobiologic into those articular processes. And now, if I had to do them twice, these are all the bad actors. They're coming in, they're bucking people off. People are showing up with their arms in slings and broken collarbones. These are all the bad actors. And we injected those horses twice. 80% of those horses I have never seen again. I have never had to retreat them. Now, what I need is several more years to follow that out to where I can say that convincingly we have fixed the problem, because that's a big say. But we haven't gotten to do it. But one of the questions we did in the survey that we did for that paper, and like I say, I hope it'll be out soon, is we asked the clients, knowing that the orthobiologics cost more and the cortisone costs less, did they think it was worthwhile? And that was a very subjective question, could only be answered by the clients. None of us can answer that. And the answer was 82% said they thought it was worthwhile. So, you know, I think sometimes, and I tell this to my young veterinarians, is that we're kind of afraid to venture out a new, more expensive modality or technique or whatever it is, because we're just assuming the client or that particular client isn't going to want it. And what I teach the young veterinarians I have the opportunity to teach is lay out all the options for them, because you never know what they really want. And sometimes it helps to explain it to them that if we can keep this horse that you love so much going longer, then you don't have to go put the big money into the next horse that you don't know whether you're going to love. Okay. You may turn out hating it, but it's all you'll have at that point. But so there's some real rationales to what we call, of course, regenerative medicine, at trying to keep these horses going for longer periods of time in a better manner than just pumping corticosteroids back in their joints. So
we've got another question in the chat. The question is, what controlled human studies are there on A2 macroglobulin?
I cannot quote those off the top of my head. I can tell you no, but we can try and there are data in the human field. It will still be sparse in comparison to, say, PRP, but the reason for that is simple. It's the new kid on the block, and where PRP goes back 30 years. But the important thing to understand, and we'll try to get Bill to make those papers available. There are some. But the important thing to understand was that what we covered at the beginning here, which is that this is an attempt to separate the pro-inflammatory mediators from the anti-inflammatory mediators. Everybody always wanted to know for this last 30 years, what's the secret sauce in PRP? Okay, and this is an attempt to do that. And it's one of the first successful attempts to do it. And understanding this molecule better gives you a rationale for why it's doing that and why it's working. And if you go back and really read some of these papers on PRP, and you'll find one is describing huge success, and the other one is describing very poor results. It didn't do better than the control. And you're going, what's that about? And again, it's because of this admixture of pro-inflammatory and anti-inflammatory that you will get depending on the disease process you're trying to treat and the way that you're doing it. I mean, look at all the variables in PRP. Pro-inflammatory, anti-inflammatory, it's coming from a biological organism that may or may not be able to produce good alpha granules in high quality and high number. You may have done a technique that did not concentrate them well. There's RBC rich, there's WBC rich, there's RBC poor, there's WBC poor. Yeah, I mean, if you read these papers, you get more and more confused. I like seeing something like this, which is someone has made it kind of simpler for me and said, okay, well, we're just actually trying to do the anti-inflammatory thing. That's really all we're trying to do. And the fact that it upregulates cartilage metabolism, that's really promising. Anabolism and reduces catabolism, that's all really promising. And so, I think it's important to understand the basic science of it and what you're attempting to do and why PRP has these highly variable results that we've seen over the years. And so, and I think, part of it is as much as we'd all love to have a whole bunch of, double blind randomized trials, in this day and age, maybe I saw that 40 years ago when, universities were still pumping out basic research. There's very little of it nowadays. And they're sure not going into these areas. So, I don't think that's going to change. We're going to see retrospectives that we can glean things from, but we're not going to see a whole lot of primary research done in this area. They're not even seeing it in human medicine, and they have a ton more money than we do. So.
Thank you. There's just some additional queries around research and papers. We've said that they can contact Kiri around specific research information, if that's okay. Any additional?
You mentioned nerve pain essentially earlier. Would it be the inflammatory mediators that are upregulating that the alpha-2EQ is then going to down-regulate? Is it directly linked to that it helps with nerve functioning?
Well, there's some excellent papers that were done years ago in England. You can't do this kind of work in the United States because we have EPM, okay, and which confuses the issue of, say, a mild to moderate neurological horse, that what's the cause, okay? And so in the United States, we assume everything is EPM first and then something else afterwards, which is not necessarily correct. But in Great Britain, they did this study, and Dickie Hepburn did the work, and what he showed was that he had 100 horses with mild to moderate neurological effects, and he did really nice job documenting them with radiology and nuclear medicine, and then he injected cortisone into the facets that were affected, neck facets. And then what he found was that he could make 3/4 of them better. Now, that is not only affecting the nerves in that area, but it's also affecting the synovium from the arthritic joint that is then pressing onto the cord. So you're getting both. If the nerve damage is from bone affecting the nerves, you know, almost anything you inject is going to make minor differences. But if it is soft tissues, be it disc, be it facet joints, any of those that are affecting those nerves, then you're going to have some profound effects. And a case I had just recently was a case that a horse came in, and I was kind of shocked at how it looked. I hadn't seen it in 6 months. And then the horse is clearly neurological. And so, you know, we immediately pull an EPM titer on it, and the titer comes back and it's essentially negative. So, you know, we're radiographing the neck and we go, oh, okay, well, we got some problems here. We injected that with A2EQ, and we did, I think, 7-1, 6-7, 5-6 on both sides. And that horse came back and looked like a new horse. I mean, it had a new lease on life. It could now ambulate normally. It just looked better. Everything about that horse looked better. We were shocked. The client was going on and on about it. You know, you hear about it on the phone and you go, yeah, right. She was right. I mean, the horse looked amazing. And that was just injecting those facets and relieving the pressure on nerves or cord. And that horse, we put it back to work where I mean, that thing was easy grade 2. You could have called it a grade 3 neurological. I wasn't so sure we were going to get it back. But so, yes, the answer is you can make some significant effects on that.
Do you ever include HA with the A2M in an example?
The HA, and people ask this question, I don't personally do that. And I could see it as a scaffolding. The interesting one, and I haven't done a ton of this, I've only done it a handful of times, but is practitioners, German practitioner was talking to me about this. And what he was doing was alternating alpha-2 macroglobulin with then a polyacrylamide gel. And his rationale was, well, I'm using the polyacrylamide gel for it also affects the synovium and the structure and I'm using it as a kind of a scaffolding. I can hold that A2M in place. And another practitioner had talked to me about that years ago, and I have to admit I kind of scoffed about it then, but now thinking and knowing what I know about it, there may be some rationale. And I certainly know there are practitioners who are using A2M and then following it with a polyacrylamide gel. And some have used HA. I think you can use any of those you like without it being a problem. I think I would not use it with cortisone. I think you're going to get into problems with that. We go to lengths to not put cortisone and an orthobiologic in the same animal the same day. Okay. I've personally never seen the effect, but if you understand the basic science and the chemistry of it, it should not be a good outcome. It's going to affect your orthobiologic.
So you could, in soft tissue, put an HA scaffold and then the A2M in there with that, using that scaffold to concentrate that ATM to stay in that soft tissue where you.
That's exactly the same reason they're doing it. I think you could use HA or polyacrylamide gel, either one. Yeah. Anything else, guys?
I think we're done.
What's that? Oh, that's not my department. No, and to be full disclosure, I'm on the advisory board for Astaria. Okay, and I got on that when they showed me the original data and asked me if I would participate in the safety trial, and I said yes, I would. But I was so impressed at the original scientific data they had. I said, I want to be on your advisory board because I want to see how this works and I want to help guide it. If it's like, I don't think I've ever made a nickel off any company I've ever gotten into in veterinary medicine. I'm not planning on it here, but I am planning on, I was pretty excited on that case. I was showing you on my asthma horse, my fox hunter, that he could do that. And that was one of the things on the advisory board. Then I could get that project going. And so that's, I have fun doing that. I'm on a few other advisory boards, but I always try to tell people I'm not trying to sell anything, and I guarantee I'm not making a nickel out of it. But I'm happy to tell you what our experiences are, and we have been impressed with this particular product.
So I can answer your question, Mike. It is pegged obviously to the dollar. We were buying it from Astaria Global, Bill Kramer, and we will endeavor to have stock in the country of the kits and the centrifuges, hopefully by August, and to maintain a stock level. There's pretty much a 6-week waiting period for me to order it from the US. But, you know, we try and keep tabs on the demand here, that there is always available kits. And as I say, the price is pegged to the dollar there. It's available for everybody at the same price. And we're going to bring it in and retail it at the same price.
Okay.
I say a huge thank you then to you, Dr. Allen. That was a real pleasure and a privilege, and we so appreciate your time in South Africa to come and do this. And we hope to keep in touch. Thank you.